Stories behind the US health insurance crisis have become all too common. The reality hits hard. Imagine needing emergency care by hitting roadblocks at every turn. Picture this. You need emergency care by hitting wall after wall in the system. It's heartbreaking. Patients with insurance coverage still find themselves grappling for the care they urgently need. From COVID exemption to mammograms, these are real actions of people facing potential life-threatening issues. What's even more gut-wrenching, if they're resorting to desperate text messages to the physicians for help, doctors like Leah Houston see it every day. The costs, the shortages, the endless wait times, and the outright denial of access and security of your health data. It's time for a change. Welcome to our podcast, CareMinds. We go deep into the physician's perspective from this rigid system. Joined by Leah Houston, medical doctor, founder, and CEO of HPEC, a revolutionary decentralized identity and credentialing application for US-based physicians, restoring privacy and trust to the practice of medicine. But before we do that, hit that subscribe button and ring the bell notification so you never miss out of our new videos. I'm your host, Pavel Tansura. Let's dive in. Leah, you're an emergency care physician for the past 10 years of experience. And you're a founder of CEO of the HPEC, a decentralized identity and credential application for the US-based physicians. You live to empower physicians to get the best care for their patients. Which life events did led you to the realization that something needs to be done to address the US healthcare crisis in regards to the care access?
Well, we as physicians have slowly had our practices co-opted by corporations, vertically integrated systems, insurance companies, and there's no more private practice doctors out there. And now we're being employed. And the larger the employer and the more insurance companies that you take, the more complex the credentialing process is. And for those who are listening who don't know what that means, from the day that I'm hired or from the day that I start enrolling in an insurance company, there's a 4 to 6 month process of credentialing and identity verification that happens that requires me to share and authenticate who I am, make sure I actually have a degree, actually have a license. And the process is basically them asking us to redundantly and repeatedly share this information about ourselves. And so there's a lot of solutions out there for people who are checking these credentials, the actual hospitals, the actual middle-sized and surgery centers, things like that. But for us, the ones that actually have to provide this information, there's no good solution. We are the end user that's experiencing the friction. So we've created a mobile identity application that allows doctors to hold, store, share, and keep permanently verifiable information about themselves. Meaning from the day that I graduate from medical school, I get a verifiable credential in my wallet. And when I share that, it comes along with provenance data that that credential is authentic and real. And that's only made possible now by decentralized identity.
Oh, that's great. And so I assume that all the things you mentioned is making the physician life really miserable. And the things that you do with credential sharing, to speed up the way to authenticate those physicians and provide real care for the patients. So it directly improves the patient outcome, as I guess. And what aspects of decentralized organization or decentralized credential sharing made obvious for you that this approach is best fitting to support your idea?
Well, you did mention patients, and it's hard for people to understand how this is going to affect patients, but there's a shortage of physicians. And part of that shortage is that I can't quickly go work somewhere. I can't onboard and get to work tomorrow. So even though it's not a direct patient to physician application that we have, it directly does affect downstream care. And so the reason that the decentralized identity portion is important also is that we as doctors communicate all the time about you, about patients. And right now, that communication is sometimes on EMRs, but that EMR is siloed. And so, unless you're talking to a doctor directly in that health system, and you're not referring out of the system, and you're not a private practice doctor, that kind of works. But you don't own the right to that communication. You don't own that connection to the other doctor. So, something that's unique within our application is that you as a doctor can build your referral network as an independent doctor or an employed doctor, whether you take cash or whether you take insurance. You can connect and communicate directly with your colleagues and essentially build a social network around yourself of colleagues that you trust with your patient's care. And so we have the opportunity to build independent referral networks outside of insurance networks, outside of health system networks, in order to get the patient the right care for them, regardless of where that patient wants to get care or is able to get care.
That sounds incredible. So, as you said, the EHR systems, they disrupt doctor and patient relationships. And do you consider your technology as a personal EHR concept where the ownership of the data, electronic, like health data, is actually goes to the patient itself without the sharing to the with the providers? Or are you familiar with this personal HR concept?
Right. And so patients only now have access to their data over portals that are tied to these centralized systems. So even the patient also has a login for the hospital that they were admitted in last month, and then maybe even a login at their private practice doctor. If they go to a urgent care center, they might not even have a login. They have to actually get things in their hands. So we're not going to be communicating patient data on this application, but we're providing identity access management for doctors to be able to pull this data from the newly developed interoperable systems that are being created by the federal government now through the US 21st Century Cures Act.
Gotcha. Now it makes total sense. And thank you so much for clarification for me. So there's not going to be the patient data stored in the application. This is designed for the credential storage and authentication of the physicians.
It does allow for permissioned access to patient data with permission from the patient, and so this application will have the ability for doctors to essentially log in and suck any patient data in of their individual patients, and then also eventually port that data into these systems or these EMRs also through a robust identity access management solution that we're building.
Gotcha. That makes total sense. What is the main bottleneck you think in terms of like position credentialing in the system right now? So you already mentioned the part of that. So it takes a long time. Maybe is there anything else to like verify physician in this healthcare system?
So there are between 30 and 70 credentials that each enrollment in a hospital or credentialing with an insurance company requires. And each of them have their own centralized database. And some of them have logins where you can log in and see the updated information. But a few of them are slowly starting to develop APIs that allow for us to pull and push information and or push information into these systems. So as we're building this solution, we can integrate into these APIs and get automatically updated information about us so that we no longer have to do those manual things. And importantly, as open standards, decentralized identity credential management systems are adopted, our application can also receive actually verifiable credentials from these institutions, whether they're state licensing boards, the federal DEA agency that allows us to prescribe, CMS, our medical schools residencies, our CMEs, procedure logs, things like that.
Gotcha. And I assume you have a personal story why you actually wanted to disrupt this industry with the innovation in your technology? And maybe you can share this as well with our audience.
Well, so as an emergency doctor, I was acting as a locums physician where I was filling in urgent needed areas. And one of the hospitals that I was working for began using my Medicare and Medicaid PTAN numbers, which are one of the credentials that we have, one of those 70. And they were billing on patient care when I no longer worked there, when I was no longer even licensed in that state. And so there's a tremendous amount of fraud, not only in the Medicare, Medicaid, but in the insurance industry. And so this is also kind of a guard against fraud against the patient. When that happened to me, I was unable to work for 5 months and having student loans and bills to pay. That was really, really a big problem for me. And even though I resolved it, I was like, we need to create a preventative tool for this to never happen to anyone else again. And so that's where the origin of HPEC came from.
Yeah, and what was the challenges for you as a founder of the tech startup? Because you came from the healthcare industry, which is completely different, and you probably faced a lot of roadblocks in your journey for the past couple of years of running of HPAC. Can you share these challenges with our audience as well?
Well, there's businesses out there that improve upon currently existing processes or current products. They make a better product. We're doing something that's never been done in a legacy system that's very antiquated, that's not very up to date. Most physicians and hospitals are still using fax machines. They're not, they don't trust email. And so doing something that's never been done before and in a very entrenched industry with a new technology that's now still being finalized and developed, responding to a new regulation, the 21st Century Cures Act, that's now still finally being developed, is not as easy as doing something that's already been done before. But it's been an amazing journey.
Absolutely, I could imagine that it's very tough to educate the market about new tech and why they should use the technology. We had the personal experience when we tried to integrate one of the software with one of the biggest healthcare providers in the US. And it was very tough because of the level of bureaucracy they have and the level of security and complexity of penetration of the new tech. So, yeah, I believe this is a very exciting but very challenging journey so far. I wanted also to ask you whether your product going to work on mobile, so it's designed to be mobile first, or is going to be also like the web version of the application as well. Because you mentioned that the fax, some physicians use fax in some of the hospitals, and I assume it needs to be adopted in some sort in their user experience. But what do you say? What you can say about that?
Well, because we're a wallet company and because we are privacy first by design, we do a mobile app. And as a physician who onboards, you can onboard for free, you can create an account for free. We create that opportunity for all doctors in the US. You build a secure enclave of your information. And there's really no way to do that securely on a web browser right now that's not super friction filled. And so that's why we're mobile app first. And yeah, it's launched. It's on the iOS and Google Play Store. Any doctor can join today and gain all of the benefits of the actual community and the referral network. And then the credentialing solutions, we're slowly integrating as these technologies are adopted.
That's awesome, and congratulations with the launch. I know this was a very long journey for you and the HPAC to launch the product, and this was sometimes it was tough sometimes, but yeah, you're still here in the game, and you keep on working on that, and that's something to be proud of. And can you share also who is your ideal customer for the HPAC?
Right. So we're creating a marketplace and the application is free. So how do we make money? So The doctor can onboard, join the app, get all the referral network features, get their wallet at no cost today. But the credential verifiers are the ones that currently pay for credentialing. And they pay an average of about $3,000 per doctor every 2 years. And so to onboard a physician to a new hospital can cost about $1 million on average. So if we automate and streamline that process, reduce the number of full-time staff members they need because this credentialing data is verified from the start, then we can reduce millions of dollars worth of cost and onboard doctors faster so they can get to work quicker. So our primary customers that are going to be purchasing the credentialing solutions are credentialing companies that build integrations into our API where they can take this data, populate their systems, and then provide this as either an additional service to their customers or, add it as it currently is. And we can also share these credentials directly. So if you have a small practice and you can't afford a large, credentialing company, we can share these and charge you a small fee per credential. And then some of that money goes back to the physician community where they can use it for governance, lobbying, different kinds of tooling that they might need. So as you participate in the network, you get points. And those points can be used for discounts on services. If we do the public profile option in the future, they can get discounts on that. Telemedicine integrations, later on revenue cycle management things, stuff like that. And so it's really exciting.
That sounds really exciting. So yeah, thank you for that.
I think the general population doesn't really understand the importance of the physician-directed referral network. You look at companies like One Medical that was purchased by Amazon for billions of dollars, I think. You look at other large $100+ million investments in doctor network companies. Where are the doctors coming from? Because there's a shortage of us. And we are feeling very underserved in this industry. So we as a company aim to be the true technology service provider for the independent physician. Whether you are employed and you have a part-time private practice, or you have other things that you're interested in outside of your employment contract, you're able to now share and own your professional brand completely, especially as it's presented to your current colleagues. But then later we have the opportunity to build a public-facing website where patients can look up doctors and know that they're verified, they're licensed, they're actually physicians, they went through medical school, they went through residency, they went through all of this rigorous training, and therefore they can be trusted. And they can see their networks of other doctors that they know and that they refer patients to and from, so that they know that the physician that they're seeing has access to the right care for them and the right referral network to them, regardless of where they work, regardless of whether they take their insurance or not, because there is a big movement in the patient population to want to be able to purchase healthcare services outside of the insurance networks because there's so much friction in the insurance networks and so much cost. I mean, there's huge monthly fees and then there's huge deductibles. The direct primary care industry, I call it an industry, but it's really a movement of independent doctors opening their private practices, having a cash-based fee that's very fair and reasonable, where you can see your doctor, connect with them directly. They can kind of coordinate and organize, reduce rates on medications and labs, and get you reduced prices on surgery. This morning I was listening to Dr. Lee Gross, who is one of the leaders of the direct primary care movement. He was giving a presentation to the Florida Medical Association. And, there was a patient that had surgery that was going to cost $45,000 with a $7,000 deductible. And he could have gotten the same surgery through the Surgery Center of Oklahoma, which is an independent cash-based surgery center in Oklahoma, for $14,000.
That's incredible. I know that the US healthcare system is broken in some way because of the insurance and companies. And The cost of insurance is very significant right now. And even though you purchase one of the best, insurances in the market, you still cannot be confident in the uh, disease treatment that they provide you and condition that they set. And sometimes you want to triangulate the decision about your care with other physicians as well, because if it's life threatening event, you want to listen about second and the third opinion before actually making decision about the surgery and about something important like that, for your life.
Correct. And in the current market, that's going to take 2 months to get the first appointment, 2 more months to get the second appointment. You have to wait 2 hours in the waiting room. And it's too much friction for somebody who has cancer, for example,
Yeah.
you know? And so this provides an opportunity for us to essentially what we call curbside consult each other,
Yep.
where we can just quickly get some feedback. We can potentially integrate telemedicine where a patient can do a quick 5-minute consult with a urologist and have 5 of those over the next month so that they can get the, second opinion from them, and they can pay cash for that service if they want to. There's a lot of opportunity to make the patient experience better that the doctor can do if they have the right tools. And so we're trying to develop those tools for them. And we're starting with credentialing, but there's an unlimited upside opportunity.
All right. Dr. Leah Houston, it was absolute pleasure to host you on this CareMinds podcast. And thank you for invaluable insights.
Thanks so much for the opportunity.
Thank you. Thank you for watching this CareMinds podcast episode. Hit the like button and write us a comment if you enjoyed this video. And see you on the next one.